Good afternoon, morning or evening, depending on which time zone you're in. My name's Professor Paul Collinson from St George's in London. And today we have three exceptional speakers giving you an update on cardiac biomarkers. First of all, Professor Kristin Aakre is going to present a discussion on how analytical issues affect accelerated diagnostic pathways. Ola Hammarsten is going to talk about troponin release from cardiomyocytes. And finally, the icing on the cake, Professor Allan Jaffe is going to present some updates on natriuretic peptides. So at this point, I shall ask Smeralda, who's coordinating this, to start off with Kristin Aakre's presentation. Take it away, please, Smeralda.
So good afternoon, everybody, and welcome to this webinar. My name is Kristin Aakre, and I am unfortunately not able to present live, but I hope you will enjoy this recorded talk. So today we will discuss how the analytical quality of cardiac troponins impact the performance of accelerated diagnostic chest pain protocols. So here are my disclosures, and here is an overview of my talk. So what do we mean by analytical performance specification? We will discuss how we decide analytical performance specification and how they are and what performance is needed. We will discuss what is an accelerated diagnostic chest pain protocol, look at the clinical studies and what they report on performance of these protocols. And also we will look at some simulation studies that use the analytical error that is known for cardiac troponin assays, and we will end up with a summary. So what do we mean by analytical performance specification? And here I must apologize for those of you who are experienced in the field, but we want these talks to be educational to everybody, and therefore we start with a very basic. So analytical performance specifications are of course imposition and bias, and those two together combined will make up the total error of an assay, and that includes the long-term for instance lot variation and also the between laboratory variation. So why is analytical variation so important, and why do we want it to be as narrow as possible, or at least as narrow as needed for the biomarker to have a good clinical performance? Well, this is an example here. If we have an absolute cutoff, which is used, for instance, in a diagnostic definition, and you have a concentration similar to that, your patient has a similar concentration, there will be a variation in the results you get, which will correspond to the analytical variation of the assay, of course. So if you have exact this concentration here, there is a 50% chance of being measured above and a 50% chance of being measured below the cutoff due to the analytical variation. However, for instance, if you have a low concentration in your patients, this is clearly below the cutoff, so this should be classified as a healthy or at least non-diseased patient. However, due to the analytical variation, there will be a certain risk that this patient is classified above the cutoff, just because, as you can see here, a few of the measurements done for this patient will actually be above the cutoff and have a risk of a false positive result. So that is for analytical variation, and usually it's quite narrow like here, but sometimes we have a much larger analytical variation, and as you can see, for this patient who was measured here, down here, there is a larger risk of being classified above the cutoff, so there is a larger risk of a false positive result. However, this only applies for this patient here, and the risk it's higher, but it's not very much higher. Okay, so that's the analytical variation. It's important to have a narrow analytical variation to reduce the risk of false classification. However, the situation is a little bit different for bias, because bias does not only apply to individual. Analytical variation is very much applicable to individual patient, but bias applies to the whole population you measure. So if you look at the example here, you have the same situation. You have an absolute cutoff here, and you have a concentration in your patient that corresponds exactly to that absolute cutoff. So there is a 50% chance of being classified as high risk, and there is a 50% chance of being classified as low risk. However, if you introduce a bias in your assay, for instance, you have a bias which corresponds to one standard deviation of your analytical variation, then you will move your patient down here, and all patients who have this concentration here will be moved down here. So there is no longer a 50% chance of these patients being measured above the cutoff. There is only a 16% chance, and this applies to everybody with that concentration. So you move your whole cohort downward, and you will, of course, then if many patients have a concentration which is around the cutoff, this can have very much affection on how many are classified above or below the cutoff. And if you have a larger bias corresponding to, for instance, 2 standard deviations, this problem will be even bigger, and only 2.5% here will be classified above the cutoff, even though it should be 50%, because they all have a concentration which is here. So bias can shift the classification of large patient groups, while analytical variation is applicable for only for the individual patients. So how do we decide what analytical performance is needed for the different measurements we have in our laboratory? Well, this has been discussed for decades and decades, and I think the last large discussion was around 10 years ago, and there was a strategic conference in Milan where this was discussed, and after that, some of the participants wrote a consensus statement discussing how we should decide the analytical performance specifications and what principles should be laid down. And they suggested different models for deciding this. And the most preferred model, the strongest model, which will provide the strongest evidence regarding that the analytical quality is good enough, is the one which is where we model the analytical performance specification based on outcome studies. So we look at either direct or indirect outcomes, and we see how the analytical performance will affect the outcome of patients. The most severe or most important outcome would, of course, be disease or death. So we could actually imagine that we had a study where we could randomize patients to high and low analytical quality of an assay and see if that could affect death. I don't think that would be very easy to do, or maybe not even ethical sound always, but that is kind of the principle. It's more common to use indirect clinical outcomes, where we look at how the analytical performance will actually classify patients, and if the analytical error will lead to misclassifications of patients. That's a much more common way of doing it. For cardiac troponins, we have both kind of studies, but not randomized trial. We have observational studies that look at how that use assays and where the analytical performance of that assays are crucial for the correct classification and outcome of the patient. We will come back to that. So, what is an accelerated diagnostic chest pain protocol? Well, this is a tool for rapid risk assessment in the emergency department. And we patients with chest pain who are evaluated for acute coronary syndrome, they make up 5 to 8, 10% of all patients who present to the ED. So this is a large group, and it's absolutely necessary that we have a rapid risk stratification of these patients. They should not stay in the ID because they will make up a very large proportion, and it will lead, which could lead to overcrowding in the ED, and that will increase risk not only for chest pain patients but for all patients who are in the ED. So to have a rapid risk assessment and find out if this is high risk for NSTEMI, low risk for NSTEMI is very important for the flow in the ED and for the overall patient safety. So what we do here is we either use clinical gestalt in combination with ECG and high sensitivity cardiac troponin measurements, or we use clinical risk scores together with high sensitivity cardiac troponin measurements. And patients are then measured at when they present and 1 or 2 hours later if that is needed. And the risk stratification is done based on that baseline sample together, if needed, with a delta value at 1 or 2 hours, if that is necessary. And here is an example from the European Society of Cardiology. This is what they recommend. This is a typical outline of an accelerated diagnostic protocol. And what happens here is that the patient presents with possible NSTEMI. You take a troponin at 0 hours and at either 1 or 2 hours afterwards. And together with the clinical assessment and the ECG, you do a risk stratification. And then if the troponin at admission is very low, that would be around the LOD. And ECG clinical findings are okay. And the patient has had chest pain presentation more than 3 hours ago. You can say that this patient has a very, very low risk of NSTEMI. So they would be classified as low risk and what is called here rule out. However, if the patient comes in with a very high cardiac troponin concentration, they will be classified as high risk of NSTEMI and can go directly to the cardiac ward. So that is rule in pathway. If they have something between the approximate LOD and a little bit higher, you take a second sample at 1 hour or 2 hours and calculate the delta value. If the delta value is stable, then it's a low risk patient. If the delta value is increased very much, it's a high risk patient. And if it's in between, well, then it's observational zone and you need more assessment, more sampling, and other investigations to find out what is the case with this patient. So this is the ESC guided pathway. It uses assay-specific cutoffs for all assay, which are shown here. There are also other pathways which are used. This is from the high stake study, where they have suggested cutoffs using troponin I and troponin T. I show here the troponin I pathway, but they have a similar for troponin T. And this is very similar to the ESC guidelines, but it's a little bit different. So this, I think both can be used, similar good, but it just depends on what is practical in your hospital. So, what does the clinical studies report on the performance of accelerated diagnostic protocol? Is it safe? Well, there is a plethora of studies reporting on this. Most of them are observational studies, which of course is not on the top hierarchy of scientific evidence, but for diagnostic studies, that is usually regarded okay. So most of these have sampled patients in the ED and then afterward calculated what would be the safety if we used this pathway. So they have not necessarily used the pathway, but they have just calculated safety measured based on what outcome the patients had if they were later diagnosed with myocardial infarction. As you can see, we have a large number of these from all over the world. This is a study that was published in the New England Journal of Medicine, where they had looked at 15 international cohorts, more than 222,000 patients, and they have used several central laboratory high sensitivity assays. And the way this works is that here is the baseline cutoffs that were used. Here are the delta values. And these are the safety measures. So for these delta values and baseline cutoffs here, there is a less than 0.2 chance of myocardial infarction or death within 30 days for those patients who have been evaluated. The negative predictive value is very high, and the efficacy is a little bit variable depending on the cutoffs used. But that was just an example for troponin I assays. They're similar for troponin T. And as you can see, this is very, very safe. There are less data for point-of-care assays, but they do exist. This is the largest studies, which is a 0-2 hour ADP, which was based on the SAMI study from Australia and the SAGE study from United States. And they also demonstrated excellent sensitivity and negative predictive values for this pathway. This is the similar data from our hospital, a 0-1 hour point of care pathway, which shows very good performance. We also have some simulation studies that measure how the analytical performance affects the ADP results. And for these simulation studies, we need to know, or it's useful to know at least, how large is the total analytical variation for cardiac troponin assay, just to know how much error should you simulate. And luckily we know this. There was a beautiful study from Pete Kavsak where they made 3 different plasma pools at low concentrations. They sent these to more than 35 laboratories in Canada and had them measured monthly for 12 months. And based on that, they could calculate, this is the target values for the different troponin assays at the different pools, and they could calculate the deviation, measurement error at those concentrations. Absolute deviation here and relative deviation here. So we know how large is the analytical error for troponins in real life, which is a very useful data. When we know approximately how large the error is, we can use that to simulate how it will affect patient data. This is from the high stakes study, 48,000 patients. They have simulated for troponin I Abbott, and this is the overall proportion of reclassification by imprecision. So here is the CV and here is the reclassification. So you can see if the CV is large, well, the risk of reclassification is also quite large. However, if you come down here and look at the likelihood of a reclassification for MI patients, the likelihood is very, very low. Even if you have 100% CB, there is only a 1% or less chance of reclassifying an MI patient into non-MI. So very safe. We have also done a similar simulation in the VESCOR data. And what we did here was this is the raw data from the patients in the VESCOR study. This is what we measured. And then we added the analytical error, which was described by Pete Kavsak in that study from Canada. We added it here. So if the measurement error was 5 nanograms per liter, we would just add 5 nanograms to all results, and we would subtract 5 nanograms per liter to all results. And then we would recalculate the sensitivity, negative predictive value, and rule-out rate for using the new data, the manipulated data sets. And what we showed here was that there was very low influence on the sensitivity and negative predictive value, almost completely similar, while the rule-out rate, the efficacy of the algorithms, was very, very much affected when we manipulated the data. And the reason is, of course, that very, very few patients, here are the STEMI patients, very few of them present with these low concentrations. So they are so few, so it doesn't matter how you manipulate the low concentration. As long as you are within the, of course, analytical error of the assay. Within that limits, you can do what you want. It affects so few patients that it doesn't matter. However, for those who do not have myocardial infarction, most of them have quite low concentrations, and they are, as you can see here, very much affected by this manipulation. So the rule-out rate will be very different. We have also done here is theoretical calculations of how the different analytical variation will affect the risk of reclassification of patients for different cutoffs values. This is purely theoretical, no patient data here, and it's published by the IFCC group, and we discuss very much around this low concentrations analytical and how analytical error affects these measurements. So I recommend this paper for further reading. So to sum up, accelerated diagnostic protocols are an essential tool in the work of patients with acute chest pain in the ED. Clinical observation studies indicate that this is very safe, good tools we can use. Simulation data confirms this, and they also add up and show that the analytical quality and good performance is very, very important for the efficacy of the algorithms so that we can rule out the correct number of patients. So thank you, everybody, and have a great evening.
Okay, well, thank you very much, Kristin. We're now going to move on to Professor Ola Hammarsten, who's a professor of clinical chemistry, and he is particularly interested in mechanisms of troponin release. So I'll pass this over to you, Ola. Need to unmute your microphone, Ola. I'm afraid your microphone's...
Yeah. Do you hear me now? Do you hear me now?
Yes, we hear you now. Off you go.
Great. Let's start. So My name is Ola Hammarsten, and I'm professor in clinical chemistry at Sahlgrenska in Gothenburg. And I will present what we currently know about the troponin release. And I was hoping that my images will come up. Do I need to do something? Is there?
We can see your slides, Ola.
Okay, you can see them. I don't see them though, but I have them beside me here. So my disclosures are listed below. Ms. Merla, you could just the next image, and what I'm going to present is shown in the next slide in a published summary of what we have looked at, and next slide, please. And in this publication, you can see that there are basically two mechanisms that I will discuss. This is not comprehensive, of course, but first one is necrosis, which is the obvious version, and the other one is the non-necrotic release that is the particular interest. The next slide, please. So the cardiac troponins, they are cardiac specific and are released, of course, after cardiac necrosis, and is used to diagnose or exclude myocardial infarction. But in many cases, you also have patients with stable troponin elevations that we are still unclear of why they are there. But when they are there, there is an increased risk of future events. The next image, please. The release of troponins, the mechanisms can basically be divided in necrosis and in other mechanisms that I will go through, that are either due to holes in the membranes called cell wounds, or an active release that is due to a type of exocytosis that will be described. And if you have a kinetic rise and fall, it can either be the release by necrosis or by other mechanisms, as I will describe. The next slide, please. If there is the next right slide, it should be an animation showing how troponin and myoglobin is being released following necrotic event. And what you see is that the myoglobin that is not bound to anything inside the cardiomyocyte is cleared very quickly, as you see in this plot here. But also that troponin T has a delayed release because it's bound to the insoluble filaments inside the necrotic cell. Next slide, please. And then you can just go forward so that you can see the different animations, and if it's the right animation, there should be a green protease that cleaves the troponins, so that the troponin I and C is separated from the troponin T that is bound to the insoluble filaments. And we think that then the next slide, that what happens is that following necrosis, this protease is cleaving off the troponin I, so that becomes released very fast, whereas the troponin T that is measured by the Roche assay is remaining on the insoluble filaments that for the large part is being degraded without reaching the circulation by the local macrophages. And you can continue to press so that you get a plot showing the troponin I and troponin T levels that you get usually following non-ST elevation myocardial infarction or STEMI. And what happens then is in the first part of the necrotic event is that you get much higher troponin I values compared to the troponin T, although the amount of troponin I and T is very similar inside the cardiomyocyte. And the reason behind this, we think, is because that the troponin I is released via this proteolysis, whereas the troponin T, for the most part, remains bound to the insoluble filaments that is not reaching the circulation but being degraded by macrophages. Then the next slide, which shows a filament again. And if you go through the animations there, what happens during the necrosis is that you get both full-length troponin with all the troponin I, C, and T complex. You get troponin I and C complex that is being released by proteolysis, and you also get the troponin T fragments that is to some extent also being released from the insoluble filaments. So you get a mixture of this in the blood of the patient after a necrotic event. And the next slide shows that you can use ratios between the full-length troponin T using a specific assays that's been developed by Mindray in combination with Fred Apple, where you can see that during an acute injury, you have a ratio between the full-length type of troponin T or ITC complex relative to the total troponin I in acute injury, whereas in chronic disease, you have much less of that ratio, which may allow us to distinguish between necrotic and non-necrotic troponin release. In the next slide, you see there's another assay developed by Sara Whitfoot in Finland that shows the same performance. In that case, she's measuring a longer version of the troponin T that is non-degraded. Using that assay, she can separate troponin elevations due to end-stage renal disease from myocardial infarction. And this type of assays seem to have a very good promise in the future in the clinic if they become implemented. However, it is possible also to look at the ratio between the troponin I and troponin T measured with the conventional high-sensitive assays. And it seems that there is some information there as well. So when the ratio between troponin I and T is high, it's more likely that this is going to be an acute necrotic event, whereas in chronic disease, you see that the ratio is usually below 1. Whether or not this can be used in the acute setting is not clear yet, but it seems to be one possibility to separate the necrotic from the non-necrotic troponin release mechanisms. So the next slide should show non-necrotic troponin release, the evidence. One evidence is based on an old study where they're using Langendorf free-hanging hearts. And in that system, when they look at the percentage of creatine kinase that's being released, this is done in the 90s. So it was before the troponin era. But the level of creatine kinase that is released is only a few percent. It's 5 to 10-fold higher than you would expect from the amount of dead cardiomyocytes that they can measure using tryptophan blue in the perfusit. So this experiment we have now redone with troponin, and it seems to be the same thing here, that the amount of troponin released in this Langendorf system is much higher than you would expect from the amount of dead cardiomyocytes that you can find. So this indicates that there is some kind of non-necrotic release, at least in this special system. There is also a lot of data showing that if you grow cardiomyocytes in Petri dish, they also release a lot of troponin, and that seems also to be much higher level than compared to what you would expect from the number of dead cells in the culture. There's also circumstantial evidence from a Danish study where they have inflated a PCI balloon in the coronary vessels just for a few seconds, and following that you can measure troponin elevation. And nobody has looked into these particular patients whether or not there were any necrotic cardiomyocytes there, but to inflate a balloon for 1 minute in a coronary vessel is not regarded to be a necrotic event. However, that has not been proven yet. So the next slide should show a grape and a soap bubble. And one thing that is important to understand when it comes to release by non-necrotic mechanisms through membrane holes is that cells are not soap bubbles because their content is basically a gel. So that even if you remove the membrane, the cell will not disintegrate. So there should be a red X in the image with the and in the next image, and if you start the animation, there is an showing that the membranes of cells have a capacity to self-repair. In this case, they have made vesicles in a hypertonic solution and put them into water. And what happens is that the vesicles swell, but instead of bursting, they burp out their content, and then they reseal the holes that are generated by this swelling. So the membranes can reseal by themselves. In this next slide, there should be an animation showing the matrix that is just below the membrane. So below the membrane, there is a framework that makes sure that the membrane is not broken or destroyed. And in the next, there should be an animation showing how there is an active repair of cell wounds whenever they occur by preformed vesicles inside the cell. And the start of this repair is stimulated when the calcium flux is coming inside the cell. So the next slide we can skip. And the final example of membrane holes is the membrane attack complex, MAC, that has been shown to form in heart failure and so forth. And these holes are large enough to allow troponin to pass through. And there are some studies from skeletal muscle shows that the membrane attack complex can cause release of creatine kinase and myoglobin without killing the skeletal muscle cells. So these are membrane holes that can actually be a vessel through which the troponin can be released. And the following image should be an animation showing what happens when proteins aggregate, and that's something that the cells want to avoid. And to avoid that, it has something that's called secretory autophagy. So whenever there is a protein that forms an aggregate, there is a system that calls autophagy that helps remove that. And part of that in the next image shows, you can just skip the animations and go to the next image where you see a lot of proteins, and you just continue through the animation so that in the protein crystal, there's sort of 100% protein, but in the mitochondrial matrix, the protein concentration is extremely high. You can continue to the next animation, and in the cytoplasm, the concentration of protein is still very high, so that the amount of water between here is not very much. So the cell has a formidable problem with keeping these proteins not stick to each other. And one thing is that it has this secretory autophagy. And this animation, if you just allow that to happen, you see that this autophagy sort of encloses things that needs to be removed, in this case, the mitochondria, and in the classical scenario is that it fuses with a lysosome, and then everything is degraded. But in cardiomyocytes, it's known that 60% of all degraded mitochondria are being expelled in something called exopheres. And this was actually discussed in the 60s by the Nobel Prize winner of discovering the lysosome, Christian Ledoux, where he suggests that the lysosome is emptying its content outside the cell. And this is one way in which troponin can reach the circulation, by exocytosis in this way. There are several studies that we can just pass through that shows that there are cardiac extracellular vesicles in the circulation with troponin in them. You can continue through this last image as well. So in summary, in necrosis, you get release of full-length troponin that can be measured with specific assays and that can possibly allow separation of necrotic and non-necrotic cardiac troponin elevations. When it comes to non-necrotic release mechanism, there seems to be several possibilities that there are membrane holes forming in different stress conditions, and also that normal turnover of cardiac troponin can be a vessel by which the troponin is released via an active process called secretory autophagy. And by that, I thank you very much.
Okay, thank you very much indeed, Ola. And now I am going to ask Professor Allan Jaffe, who's been around in the troponin and biomarker field for even longer than I have, to enlighten us on new uses of natriuretic peptide measurements. Take it away, Allan.
Thank you, Paul. Hopefully you can hear me and you can see the slides.
We can do both.
Good. Today we're going to talk about a very important new initiative that's been developed to identify high-risk patients who are at risk of developing heart failure, and with the use of natriuretic peptides. It's a very valuable initiative and in the long run will be helpful. On the other hand, some of the suggestions that have been made are not necessarily in keeping with some of the analytic problems that we all know exist with natriuretic peptide values. So I want to go through that just a little bit and both sensitize you both to the initiative and then to some of the potential problems. Whoops. In this slide, you can see something we've known for a very long time, and that is that although we have a variety of cutoff values to look at acute heart failure, and they're very high, that values that are substantially lower are also predictive when one looks long-term, whether it is men, women. It's very similar to what occurs with troponin. And this has been levered by multiple groups. This comes from the ERIC study that basically shows one can utilize biomarkers such as troponin and NT-pro to identify patients who are at risk for heart failure going forward. We've done similar studies in a study we did in Olmsted County, where we looked at the 80th percentile of BNP and a high sensitivity troponin, again, to predict heart failure. And what you can see is when both were increased, one had a very substantial increment of heart failure. And when each one individually was increased, one also had a signal. Now, initially, it was not so clear what we would do with this, because although we could identify those patients, the question was, could we do something about it? And what has happened in the field that is extremely exciting is that we now know that there's something that can be done. The first such study was a study called STOP-HF, shown here. And the basics of this study were that primary care physicians in the UK had the ability to get a natriuretic peptide value. If the value was over 50, patients were either randomized to usual care or they were referred usually to a cardiologist. This is just a generalized slide of all the demographics. But what I show you here is that we're not talking about huge levels of natriuretic peptides. We're talking about individuals who were at risk because they had some additional risk factors, but who had natriuretic peptide levels 80, 90 or so. If one looked over time, those participants who had a value of greater than 50 and who were sent usually to a cardiologist had a better prognosis. What meant usually was the imaging was done, and often those patients were unmasked to have what we will define in just a couple of minutes as stage B heart failure. There was a second trial as well called Pontiac that looked at diabetics who we know are uniquely at risk for heart failure and randomized them if they had an NT-proBNP value of over 125, again, not at the levels we talk about with acute heart failure, to an ACE inhibitor and beta blockers, lisinopril and carvedilol specifically. And at 2 years, there was an improvement in outcomes in the group that was treated. Those outcomes are shown here. They're cardiovascular events and heart failure events predominantly that are important. Finally, in the therapeutic realm, we now have SGLT2 agents as well as GLP-1 agonists. And if you look in every group, regardless of natriuretic peptide values, there was benefit in terms of heart failure prevention. The way in which this fits into the thinking of those who do heart failure is shown here. There was years ago a universal definition of heart failure made, and what you had suggested was that those patients who were at risk would be called stage A, those who had structural heart disease but were not symptomatic were stage B, and then stage C and D were those who were symptomatic and who could easily be identified, and they could be classified as heart failure with preserved or with reduced ejection fraction. Heart failure stage 1 just shown here. The comorbidities that are involved are indicated. But here's the group that is most interesting from the point of view, in particularly, of those people who deal with diabetic heart disease. And that is, these values, they have structural heart disease, but they're not symptomatic. And why might they not be symptomatic? They may not be symptomatic because they're not terribly active. They're not aware of their symptoms. All of us, when we have symptomatic problems or problems of one sort or another, find ways around it. And so if we could identify these people, it is very likely they would benefit from therapy. So what the Diabetes Association has done is to help generate, with the help of the heart failure group of the European Society of Cardiology, some criteria for dealing with this group. These slides predominantly reflect the suggestions from the heart failure group, because they are by far, in my opinion, the most conservative and the most rational ones. And despite that, we'll talk about some of the issues that are terribly important in regard to how we use natriuretic peptides. The heart failure group has suggested that if you had a value in a person who is walking around in the outpatient setting, that using a value of 125 makes heart failure itself, symptomatic heart failure, unlikely. They suggest for diabetics, who the Diabetes Association now suggests should have yearly values of these, that if you have a value over 125 and you're between 50 or less than 50, you have been ruled in, and there are age-dependent cut values for older individuals with diabetes. These actually are not terribly irrational. This is an analysis of the cut points and the sensitivity and specificity. And what you can see is that these cut points for outpatient heart failure give you good sensitivity, but please note they have substantial difficulties giving you very much specificity. So there is at least some degree of evaluation necessary in this group, even if you have the values that are suggested to be diagnostic of outpatient heart failure. Where it gets more complicated is in the following scenario, where the suggestion is looking for stage B heart failure, one should get an NT-pro value and consider a rule-out value of less than 50 as making heart failure unlikely. Age-adjusted rule-in values of greater than 75, 150, and 300. Again, very much lower than the acute heart failure activities. And if indeed you're between the 50 and any of these values, one suggests that one have repeat NT-proBNP in 12 months. Now, there's some difficulties with this particular algorithm, in my opinion, and these data in part come from a manuscript which was published by the IFCC group in CCLM, alerting clinicians to the potential problems that could occur. First of all, these are NHANES normal values with presumably no cardiovascular disease. And what you can see, if you take the values in women, that you're going to have a substantial number of women, in particular, who, as we all know, tend to have higher natriuretic peptide values than do men, as at risk for stage B heart failure, just because of their normal values. In addition, we all know that there is a relationship between these values and weight and BMI, with BMI, higher BMIs being associated with lower values. So one could mask heart failure and miss it because of weight, which is commonly a problem in diabetics. This is thought to be due to two reasons. One is that there are clearance receptors in adipose tissue for natriuretic peptides. But in addition, it's thought that adipose tissue is associated with a deficiency in the stimulation of natriuretic peptides. Because of this effect predominantly, if one looks at a recent publication for ruling out heart failure in patients who have possible HFpEF, who have gone to the cath lab. So this was a very highly selected population, but you can see the rule out thresholds have to be very, very low before you really are sure that you have ruled out. And the same thing, the rule in thresholds have a tremendous degree of variability, even if one has a group of symptomatic patients such as these. Nonetheless, the rule out value of 50 is probably the most reasonable. Another potential issue with this has to do with the fact that there are some racial differences. Black individuals tend to have lower natriuretic peptide values. Some people have hypothesized that this has to do with a natriuretic peptide deficiency that may explain why there is more hypertension in these individuals. Nonetheless, it's important for clinicians to understand that one may not be able to use the exact same values in certain racial groups as in others. In addition, all the comorbidities that cause heart disease, this is an example of atrial fibrillation, also change your natriuretic peptides and tend to elevate them. Now, you might argue, okay, you've got atrial fibrillation. By definition, maybe you have heart failure. And that's not an unreasonable speculation, although it's not true in every instance. So when we look at these guidelines that are proposed for the evaluation of diabetics and recognize that eventually it's very likely these will be extrapolated to other quote unquote high risk groups, there's several problems. First of all, and I didn't emphasize it too much, but it was on the slides, you all know there's a great deal of variability between BNP assays. They don't correlate one with the other. So each individual assay is going to need to provide some degree of data concerning what these cutoffs are. It's unlikely that cutoffs for BNP are going to be the same for each. It's also possible that that may also be the case for NT-Pro assays. The original NT-Pro BNP assay was made by Roche. They licensed it to everybody else, but that's far off patent. And there are now a variety of NT-Pro BNP assays, some of which may well utilize the same metrics, but some may not. And one must make sure that whatever assay one is using is going to give you values that are going to provide the performance we talked about. There may be differences depending upon the assays and the stability of the samples. We know that's for BNP. It's not clear. It's different for NT. It usually is different for NT-Pro BNP, but again, could be a problem. There's the effect of the comorbidities, one of which I showed you. There's an impact of age. With age, as was suggested by the criteria, values tend to go up. Same thing with sex. Women have higher values. I showed you some data about differences in race. And finally, there is a very high degree of biological variation. So let's look at a couple of these for a moment. This just looks at the ability, if you take spiked natriuretic peptide fragments and give and ask which assays measure them and how much they measure, you can see the tremendous variation. Secondly, another example, there's a lot of biologic variation in all natriuretic peptides. If this looks at week-to-week variability, remember, natriuretic peptides are physiologic activators. They need to go up when we exercise, when we change position, etc. Natriuretic peptides, in particularly at low levels, this is in a heart failure group, change during the day. So if you want low levels, you need to get your sample in the morning. If you want higher levels, get it in the afternoon. And if one looks at biologic variation, these are data published by Allan Wu some years ago, you can see that you need, for an RCV to know that you have a significant change, in particularly week to week, is 50%. And to be honest, if you look what is called biologic variation and the RCV usually has to be almost double this to be sure you've exceeded conjoint biologic and analytic variation. So not only is the baseline value something that could be a problem depending upon how clinicians use it and think about it, but the change criteria when they change and repeat this at 6 months as suggested by the guidelines, or yearly, which is now the guidance for every diabetic, these change criteria could be terribly important if clinicians don't understand that you need marked changes in order to be sure you have a significant change in the values. So some suggestions. Well, we need better studies to define the assay-specific thresholds. Whatever decision is made by groups who are taking care of diabetics, it must take into account these demographic and clinical characteristics. From the lab point of view, changing natriuretic peptide levels, in particularly if one has an ongoing program where one is doing this, really could cause tremendous dysfunction unless one is terribly cautious and makes sure one communicates about this carefully. In the ideal world, it'd be nice to do the measurements at a constant time of the day so you avoid circadian rhythms. And one might even consider obtaining a baseline sample even before one has concern for any cardiovascular disease, just for comparative use. And finally, one cannot consider small changes as definitive. These sorts of caveats are terribly important if we want to use natriuretic peptides carefully. They're not caveats that have been reflected as aggressively as one would like to see in the suggestions and in the guidance for use of natriuretic peptides to clarify and try and identify those patients with stage B heart failure. So it is going to turn out to be an important task for those of us who measure natriuretic peptides to help clinicians understand these very important caveats. With that, I'll stop and be open for any questions if you have any. Thank you very much.
Thank you very much indeed, Professor Jaffe. There are a couple of questions which have popped up in the chat. The first one is saying that can this material be sent out? That won't be possible, but the entire seminar will be available on the IFCC website, particularly on the IFCC cardiac biomarkers website, so that you can review the material at your leisure. The second question concerns disappeared, was about the role of troponin, high sensitive troponin for diagnosis. I think I can sort of kick that off by saying, really, high sensitivity troponin measurement is now considered to be the methodology of choice for diagnosis of acute myocardial infarction, and is in fact recommended in the universal definition of myocardial infarction. I don't know if you'd like to add anything else to that, Alan.
Well, no, I think it's important that nowadays in the modern era, the use of high sensitivity troponin, as suggested in Dr. Aakre's talk, is terribly important. It facilitates the much more rapid evaluation of these sorts of patients in the emergency room. And with that, at present, it does not appear that there is any benefit for the use of other markers at all.
The second question, which follows on for that, is about NT-proBNP for diagnosis and management of heart failure. And again, I think here, in summary, this is the recommended marker, but cannot be used in isolation. It has to be used as part of a clinical assessment of the patient. Any further comments on that one, Alan?
Yeah, I think one of the well-intended ideas that undergirds this program is that, gee, we're not very good at detecting this. We should just rely on natriuretic peptides. And again, I think if you just rely on the natriuretic peptides, you may end up doing an excessive number of echoes, in particularly in a repetitive mode, if there are changes over time, unless we can sensitize the clinical groups that are doing this to understand the difficulty and the fairly high degree of biologic and analytic variation that needs to be taken into account in addition to these other clinical parameters.
Okay, and the final question here is, what emerging cardiac biomarkers show promise for improving diagnosis and treatment of heart failure? I will answer that by saying none. Alan.
Well, there are some interesting ones that are in the pipeline, and I'm not sure we're there yet, but there are a couple that are promising in the long run that we can look at, and but they're in clinical trials. There is nothing that is close to clinical implementation at the present moment.
We've got a question here about impact of neprilysin
on natriuretic peptides.
Yeah,
it is the case that neprilysin inhibition with sacubitril, which is a neprilysin inhibitor that is part of Entresto, does partially degrade, but only a little bit, BNP. It does not seem to affect NT-proBNP. So initially, right after use, one can see a reduction in NT-proBNP due to the beneficial effects of the agent, whereas BNP may rise a little bit and before it then tends to equilibrate. However, in the long run, BNP works just as well once one has gotten over this initial period. An important issue from that got confused about this is that the suggestion was that because of this effect that I just described, that BNP was the mechanism by which neprilysin inhibition occurred. That's probably not the case. There are a variety of other substances, substance P, adrenomedulin, and the like, that are also markedly impacted by sacubitril and likely are the more important mechanisms. But the little confound of BNP early is something that clinicians should be aware of, but it's not as big a deal as it was initially hoped to be, because long-term it seems to still work.
All right. Next question we've got is it effective to screen diabetics for heart failure in primary healthcare facilities? That's one's for you, Alan.
Well, I mean, that's the thought. The thought is if you get a BNP, NT-proBNP, and it meets certain metrics, those patients, the suggestion is, should be evaluated for stage B heart failure. I can see this happening on a one-time basis. My bigger concern is at the very low values. If the values are higher, I think moving forward and looking once is important. I'm not sure I'm nearly as happy with the idea that this gets repeated at 6 months or at 1 year when there are only minor changes. There would need to be major changes from my perspective to do a second evaluation subsequently. I think that's one of the weaknesses of the suggestions at present.
I think that's an excellent point, Alan. Got one here for Ola. Is there any evidence concerning the effect of cardiac fibrosis on necrotic and non-necrotic troponin release?
Well, the short answer is no, because we haven't studied necrotic and non-necrotic release in clinical studies as yet. But the new troponin assays might help doing that type of studies.
Okay, very good. The Next question really for Alan. What's the appropriate frequency for patient follow-up for natriuretic peptides in your view?
Well, I think it's what you're using it for. In the acute heart failure setting is usually obtained in the emergency department, and often it's worthwhile getting a value before people go home to be used as a comparator should they come back. In the screening circumstance, it's probably worthwhile to get natriuretic peptides at some point in time. And I think the idea, if one starts to think about this, of having a baseline for a given diabetic is probably not a terrible idea. And then to utilize it, in particularly if the clinician has a suggestion that the patient is having any difficulty, since most diabetics, both with a combination of diabetes, often have hypertension with it. Getting this done once, I think, is a reasonable thing. Pursuing it thereafter probably would take larger change criteria than are now advocated.
Okay. Next question we've got is, it says, since there is no point of care method for high sensitive troponin T, is there any danger of using it with a point of care troponin I method when the central lab has high sensitive T? Well, I'm not going to answer this directly, but what I would direct the questioner to, there's some frequently asked questions which we have assembled on the IFCC Clinical Biochemistry Cardiac Marker Group website that deals with this specifically and in some detail. And we also have prepared 2 expert papers, one of which is currently available in CCLM and one of which is in the final stages of preparation, which really does address all of this in some detail. The next one is how to overcome the increase in troponin T in CMS patients. I'm not sure what I know what a CMS patient is. Chronic. Any suggestions, you two?
I wonder if they're asking about chronic skeletal muscle disease, where there is known to be increases in troponin T associated with chronic skeletal muscle disease. The confound is that often patients who have chronic skeletal muscle disease also have cardiac disease as well. So one has to be circumspect before one decides that that's really what is ongoing and that this is only due to skeletal muscle. And in that circumstance, being able to order and check an alternative assay is often extremely helpful in unmasking this. Now, one has to be careful because it is the case that troponin I is less apt to be elevated in a variety of non-ischemic etiologies of myocardial injury. So it's not perfect, but that's something that one needs to be careful about and think about in those patients who have chronic skeletal muscle.
Yeah, I can add a rider to that. It's not just chronic skeletal muscle. Any situation where there is acute muscle injury, as I found out myself when I had polymyalgia rheumatica, that can actually put your troponin T up as well. Fortunately, without raising my troponin I, I'm pleased to say. But basically, if there's troponin T elevation in someone that has musculoskeletal symptoms, it's best to measure the troponin I and then see whether it's an acute or a chronic disease. So I've now got another question here, which is, can you measure NT-proBNP in pleural fluid as an adjunctive marker for heart failure? To which I would say, I've no idea.
I don't know the answer to that one either. We have a pretty active program of looking at non-blood assessments, but I'm not aware that anybody has shown that one way or the other. It's a pretty stable molecule, so my suspicion is it might work, but I wouldn't want to send anybody to do it without additional information.
I think that's fair comment. Question now is is troponin T, well, two joint questions really. I think for troponin I or T, which is recommended for MI, and I think we could all agree that we don't think that there's any difference between the two. But are there differences between T and I? I think the answer to that is yes, there are. Most notably when you have chronic injury, which is, especially if it's chronic non-cardiac injury, where you can see more elevations of troponin T than troponin I. And I'm going to pass that over to both Allan and Ola for comment.
Yeah. When it comes to interference, which is actually something that causes false elevations in several percent of normals, it seems that troponin I assays has more problem of that sort compared to the troponin T assay that is currently in use. But that's only a few percent of normals that have this problem, but it is still important to know when you work with troponin I assays.
I might indicate that Ola started to express the developing field of fragment analysis, and it is conceivable that the reason why in some circumstances, such as chronic skeletal muscle disease and to some extent in ICI myocarditis, troponin I tends to seem to lack sensitivity, could well be that there are alternative cleavages of the peptide when it's released from different mechanisms other than acute ischemic necrosis, and that with the ability to measure different fragments, it may turn out in the long run that we'll be able to develop assays that would specifically begin to add information in this important area. It's one possibility. It doesn't have to be the case, but it's at least possible.
As we're running a little bit out of time, I'm just going to answer another couple of questions. There's been a question about macrotroponin, how to deal with it in clinical practice. I really would recommend, in fact, we have written an IFCC paper on this with Ola Hammarsten as first author, which discusses macrotroponin and its detection in great detail. And I really would recommend that rather than us discussing it just now. Is that a fair comment, do you think, Ola? Yeah. Next question is from Sharon Geegan. Hello, Sharon. How nice of you to join us. Has your lab added interpretive guidance for BNP use, such as testing variation with time of day, etc.? Allan, one for you. Have you send out such recommendations?
We have not. We did share the guidance paper that we published in CCLM with our diabetic group, so that we offered to meet with them and discuss what it might be that they might need. Thus far, they've not taken us up on that offer.
Okay, well, I think as we started 10 minutes late, but we're just about coming to the end of it. I'm going to thank everybody for attending this webinar, and I'd like to thank Professor Aakre in absentia, and also Allan and Ola directly, for really very stimulating presentations. Thanks obviously to the IFCC for offering the e-learning tool. If there are unanswered questions in the chat, we will be answering them directly to you by email. Please remember, so don't worry, you haven't been forgotten or ignored. The certificate of presentation provided at the end of the webinar after a few questions. You need to do the questions and then show me my scores, and you need to get a score of at least 75% in order to get CE credit. Finally, just to say that the webinar will be available after a relatively short interval to replay in the comfort of your own time with a glass of something refreshing, whatever takes your fancy. And just to say that there will be other IFCC free webinars, and they'll be announced via IFCC communication channels, emails, website, and IFCC social media. So thank you very much all for attending, and farewell.